Thank you for the opportunity to present what we do here. Thanks.
Thank you so much. Now we move on to our next presentation. We are crossing over to America. We are crossing over to Brazil. Prof. Fernandes, may you please share your screen so that I can introduce your profile. The host, please allow Prof. Fernandes to share his screen. The host, please allow Prof. Fernandes to share his screen, please.
Yes, he is live now.
All right, thank you. As he shares his screen, Prof. Fernandes is not a new face to us, having been in Zimbabwe sometime before the COVID-19 pandemic disturbed things. He actually came to train us at some point in time. Full name, Professor Luis Flavio Cordeiro Fernandes. He's an obstetrician and gynecologist with a fellowship in minimally invasive gynecology surgery from AAGL, which stands for Elevating Gynecologic Surgery, founded as the American Association of Gynecologic Laparoscopists. He is an obstetrician and gynecologist with a specialization in minimal access surgery. He is the coordinator of the specialization course in endometriosis and minimally invasive gynecology at the Hospital Sirio Liberio, and is an associate director of the fellowship in minimally invasive gynecologic surgery in Sao Paulo, Brazil, and is a consultant and lecturer at the University of Sao Paulo. Prof, please take over and go ahead.
Good morning to all of you. Do you listen to me clearly?
Yes, we can hear you clearly, Prof.
First of all, thank you very much for this invitation. You must know that my visit to Zimbabwe 3 years ago was a mark to me. I would like to thank Dr. Dragana, Professor Svansara, Dr. Mareri, and all the others that gave me such a warmful reception. And so to me, it's an honor to be here at this moment talking to you. I would like to excuse a little bit my connection because since the change of the date, today is yesterday was the birthday of my daughter. So we are not in São Paulo, we are in a facility around São Paulo, but I wouldn't miss this for nothing. So we're gonna talk about the endometrioma. After seeing all these challenges about the deep endometriosis surgery, the endometrioma surgery wouldn't be as technical as those challenges for this deep endometriosis surgery. But the decision and the repercussions of this surgery must be taken into account before performing it. So let's understand a little bit about this disease and about this commitment. The endometrioma normally has a fibrotic tissue that has a thickness of 1.4 to 2 millimeters. 81% of this endometrioma is surrounded by ovarian tissue, but we must understand that not all of this capsule is endometriotic tissues. This capsule is recovered by endometriotic tissue, around 60% of its surface, but around 40% of its surface is composed by fibrotic tissue. This endometriotic tissue, depending where it is in this capsule, penetrates in the wall up to 1.5 millimeters. The biggest penetration, biggest is the wall thickness. We must understand that in the concept of the treatment. Another thing is we must understand we must understand the presentation form of this pathology. We have a peritoneal or superficial ovarian endometriosis, as you can see in those pictures, just attacking the surface of the ovary. We have the cystic penetration, the cystic presentation, and in the cystic presentation, you can see on your right that we have a capsule. We can clearly see a fibrotic capsule and a niche of endometriotic tissue starting to invade this capsule. And we also have some intraparenchymal presentation that is in the intimacy of the ovarian stroma. Okay, understanding this, today I think the main concern of the endometrioma is its relation to infertility. And we comes to a great doubt. What comes first, the chicken or the egg? What caused the infertility? The disease caused the infertility, or we have to take into account that sometimes what we perform, the surgery, the treatment of the endometrioma would cause the infertility. So let's understand what are the repercussions of the ovarian endometriosis. We know that if a patient has an important pain, she's committed with pain, and we find in a normal ultrasound ovarian endometriosis, we have to take care and pay attention to look further for an extensive deep endometriosis. We have to consider the ovarian endometrioma as a marker of a more extensive pelvic disease if it is related to pain. So normally, the ovarian endometriosis by itself is not the biggest responsible for the symptoms of pain of this patient. Okay, so if it's not related too much with the pain, let's see if the disease, what is the repercussion of the disease itself to the fertility. We know that comparing patients with endometrioma and without endometrioma, the presence of endometrioma by itself is related to a reduced level of anti-Müllerian hormone. Comparing to other kind of cysts, ovarian cysts, and comparing also to no disease in this ovary, we can affirm that the disease is related to a reduced MNH level. And women with endometrioma experience this progress decline in serum MNH levels, and this decline, which is common to women, is faster than in those women that has no disease, in healthy women. But okay, we can say that the endometrioma is related to a reduced MAH levels, but what is the final repercussion of this reducement in the fertility itself? Let's see what is the repercussion in the spontaneous ovulation. So we're studying women with unilateral endometriomas, comparing both ovaries. Studying around 1,200 cycles, majority didn't find difference in the laterality of the stimulation of this ovulation. So we cannot affirm that even though the endometrioma is related to a reduced age level, that the ovary with endometrioma has less stimulation, less ovulation than those without or those healthy ovaries. Chaperon recently demonstrate also that, on the contrary, that the previous endometriosis surgery, even peritoneal superficial endometriosis, age, and the number of sites of deep endometriosis, that they are related to infertility. Ovarian endometrioma by itself wasn't found as related per se with infertility. And if we do hyperstimulation to these women with endometrioma, study once again unilateral endometriomas, Somigliana made a review, a nice review, that showed that the laterality didn't change. What can I say about that? It's like, I mean, women with one ovary with endometrioma, the other ovary with no disease, a health ovary, submitted to a hyperstimulation, to a IVF, for example, they didn't find difference between the laterality. So it seems that the endometrioma by itself did not affect the response of the hyperstimulation. What about in the IVF impact? Comparing the ovary with endometrioma and the ovary without endometrioma. And also, Almoa did not find difference in the results with comparing the ovary with people with and without endometrioma. What about the impact in the IVF? Even though the endometrioma is related to a reduced number of oocytes retrieved, an elevated number of the cancellation rates, it was not related in a difference of antral follicular count. They have a similar rates of live birth, and they have also a similar clinical pregnancy rate. So the endometrioma by itself, just the presence of the endometrioma, seems to not affect that much the results of IVF. But until now, it's recommended to operate endometrioma bigger than 4 centimeters to differentiate, but for some kinds of cancer. I deeply think that with the improvement of our diagnostic tools, this Kabbalistic number will change, and will be supported to not operate endometrioma with that purpose. So the indication of surgery maybe will change in a little future. But when we will perform the surgery, we have to be nice and gentle, because even though this kind of surgery is not related to complications at the moment, but it can have deep repercussions for the women in their future life, because we are talking about an organ that has a lot of functions and is responsible for a lot of characters of the women. So we have to deal with the endometrioma nice and gently. Normally, an axial surgery is left by to our fellows in the beginning of their training, but we have to put in their mind that what they are doing can have a lot of complications regarding especially the infertility in the future to these women. So we have to be nice and gentle and perform when is recommended, and we'll talk about that later, a nice cystectomy with just little coagulation to not damage too much the ovary surrounded by this disease. So we talked about the repercussions of the endometrioma itself. But what are the repercussions of the ovarian endometriosis surgery? What are the repercussions of the treatment of this disease? We must know that we said that in the beginning of the presentation, but the endometrioma is surrounded by normal ovarian tissue. And this normally, when we perform this cystectomy, normal tissue comes out as well as the cyst. So biggest the cyst, biggest also the normal ovarian parenchyma that will be excised. Just to have a number in our mind, 1 centimeter of cyst is related to 200 micrometers of ovarian normal parenchyma. And what are the repercussions in the AMH levels after surgery? We can see here a deep decline in the AMH level that will recover a little bit after 3 to 6 months of surgery. And this decline is greater than in patients without endometrioma. And this decline is deeper when the disease is bilateral. So those women with bilateral endometrioma must be looked very, very careful. And we have to talk previously to the surgeon with them to make them understand the decision that we have to make together. Sometimes to do not operate both ovaries at the same time, or do not operate and respect one of them in order to preserve their fertility. And in this study, UNIS corroborate with that result that comparing unilateral and bilateral endometrioma, the repercussion and the AMH is deeper and greater in women with bilateral disease and bilateral surgeries. Also, Kocha showed recently that the surgery for the bilateral endometrioma is responsible to a greater reduction in the number of follicles, the oocytes collected, the number, the clinical pregnancy rates per cycle and per embryo also. Another situation that we must take care of is the recurrence of the endometrioma and the impact of the second surgery. We understand that the surgery itself, by this time, that the surgery itself has a repercussion, and the results of the infertility of the IVF, of the hyperstimulation of this topic. And when we perform a second surgery, this reduction is even greater. So we must try to avoid a second ovarian surgery at most. What about the responsiveness of this ovary that has been operated to hyperstimulation? We've seen before that the endometrioma itself did not affect the results of the hyperstimulation, but the ovary, comparing the operated ovary to the normal ovary, we can affirm that the results in the operated ovary will be worse than those in the control ovary. And also, how we can predict this response? We have to study before the surgery these follicles reserve. We have to understand their AMH level, and we know that a preoperative serum anti-Müllerian hormone has a correlation of the impact with the impact of this surgery. That high AMH level before surgery will be related to a biggest rate of cumulative pregnancy after. So these must be studied before doing any kind of procedure. And the endometriomas itself, so will not, the surgery will not impact, will not increase the results regarding the live birth rate or the clinical pregnancy rate. So the endometriomas should not be operated with the purpose to improve ART outcomes. So we have to know the purpose of that surgery, and it's not a fertility surgery normally, generally speaking. But when we have to perform this surgery, the experience of the surgeon is of great importance, because comparing a group of fellows and surgery performed by fellows and compared to surgery performed by a more experienced surgeon, we know that the fellows in development take out more normal tissue than those more experienced. So even though it's not so a challenging procedure, we must do it nice and gentle to not, or to mitigate a little bit the repercussions in the future for this patient. So if the surgery has its impact, we are trying to look of different modalities of surgery to see if has less repercussions in this topic. And we are starting to do more and more, but with caution so far, the laser vaporization on this capsule. But we have to understand that the endometriotic tissue can invade a little bit the capsule. But comparing the cystectomy with the vaporization, so far we can see that the vaporization preserves a little bit more, even though they do not have a great difference compared to cystectomy, but it reduces a little less the impact in AMH level or in the decline comparing to cystectomy. And another topic that comes to our mind when we think of these conservative surgeries is the rate of recurrence after this procedure. But Massimo Candiana has shown recently that this recurrence rate is close to those of those patients that has been submitted to the cystectomy, and is associated with similar pregnancy rates when compared to the standard procedures. The challenging of the vaporization is to do when the cyst is big, is too big, because the fiber is so thin, and also we have to take care to expose all those all the capsule, to make sure that all the surface has been vaporized. So in those patients that we understood that the surgery by itself has a fertility repercussion, we have to offer to those patients the possibility to do some kind of cryopreservation, even oocyte cryopreservation, or even embryo cryopreservation. We have to offer of course, this will increase the costs of the whole treatment, but we have to do that social fertility preservation, or offer that social fertility preservation. And this has been, this topic has been studied more and more around those years, the cryopreservation related to endometriosis. And this year, Chuck Miller made a flow chart to try to orientate what to do in situations when with patients with infertility and endometrioma. So those that has some indication of surgery, we have to offer them the possibility of embryo oocyte cryopreservation. Then the surgery would be performed by cystectomy or vaporization if you have the technology, but discussing with the patient all the possibilities that the vaporization is under study regarding the recurrence rate and the successful rate in dealing with this situation. And then depending of the age of the patient, let them try to conceive. But I argue about the size of this indication. That's a number that I think we will increase in the near future. In those patients that has small endometriomas, nothing has to be done, and the patient must try to conceive by itself. If it fails, then ART must be offered. In those situations that the patient, the doctor sees a rupture risk, that is not very common for endometriomas, because the endometrioma normally is attached to the posterior leaf of the round ligament. But if you identify any risk of rupture, then you will do a cystectomy or a vaporization previous to the procedure, the infertility procedure. If there is no risk of this kind, we have to understand the follicular count, the antral follicular count. And sometimes, if it's not a small follicular, low count, nothing has to be done. But if it has a low antral follicular count, so maybe the surgery can improve, maybe by the pressure of the endometrioma, can improve a little bit and the surgery would be an option to this patient that has this ovary already affected. So in conclusion, cystectomy should not be performed to improve ART outcomes by itself. If surgery is necessary, since we understood that it can have a repercussion in the fertility outcomes, we have to consider conservative approaches and consider also oocytes or embryo cryopreservation prior to the procedure. I would like also to invite you to our meeting here in Brazil, but will be a hybrid meeting. You can join it virtually. That is MIGS 2021, and if you let me, I'll send our folder for you. We're gonna have speakers from all over the world. It's gonna be a very robust program talking about endometriosis and all other topics of advanced minimally invasive gynecology surgery. Thank you very, very much.
Thank you very much, Prof. Fernandes, for that very insightful and educative presentation. And thank you so much for taking your time to actually prepare such a robust presentation. And we accept the invitation to the virtual conference. We'll definitely be attending. I will leave time to just 2 or 3 burning questions, starting with Mr. Mzamiri. Mr. Mzamiri, please go ahead.
Thank you very much for that talk. Just a quick question. What are your thoughts regarding sclerotherapy as a treatment option for endometriosis in aiming to, and with the impact on fertility outcomes?
You mean guided by ultrasound?
Yes, indeed. Ultrasound guided sclerotherapy and using alcohol, ethanol. So,
you know, we have a fellow here, a postgraduate student that has a project regarding this topic, sclerotherapy with alcoholic solution. So I cannot affirm or say anything at this moment that it would have an impact or a positive impact in fertility, but also we cannot say also that would be a modality of treatment to endometrioma, a real modality of treatment of endometrioma, because what I think at the end is why do we perform the surgery for the ovarian endometriosis if it's not related to pain? If it not in most of situations does not increase the fertility outcomes, we have to take care of this organ, to preserve this organ. So, but the sclerotherapy regarding this purpose, I don't know exactly the role of the sclerotherapy. So, but we are curious about that. That's why we have a postgraduate student in this line. So hopefully in a little bit I can give you a more robust answer. At this moment, I do not consider that too much. Just to be direct at the end, okay?
Okay, thanks. Yeah, thank you very much. Just that, yeah, some fertility specialists, I would argue that in order to avoid surgery, using sclerotherapy would reduce the size of the endometriomas, and therefore you won't meet that threshold to intervene, and we'll proceed with fertility treatment without recourse to surgery.
What I think is important in the ovarian surgery and regarding the treatment of endometriosis itself, it's what you showed, Professor, that is the resection of all the endometriosis in the posterior leaf of the broad ligament. That is important, and sometimes is not well recognized, and people do not understand the difficulty of of this surgery because it's related to all the vessels in the ureter, and if you go a little deeper, also the somatic innervation. So this is, I think, it's the more challenging part of all this manipulation.
All right, thank you very much, Prof. Fernandes, once again for your very insightful presentation. We look forward to more presentations from you in the future. And we also look forward to your coming to Zimbabwe once, international travel improves a bit and the situation normalizes. So thank you very much. Without wasting much time, I'll move over to the next presentation. May the host please allow Dr. Ngwaru to share his screen so that I can introduce his profile. Dr. Ngwaru, may you please share your screen?